Let's talk about thrombocytopenia background. So platelet function is mostly affects bleeding into the mucous membrane. Usually, common presentation include petechiae, eczemosis, epistasis, gingival bleeding, abnormal uterine bleeding, hematuria, and GI bleeding. Definition: less than 150 times 10 to the ninth power per liter. And this definition is somewhat arbitrary. Um, Normal platelets in pregnancy can be as low as 100 times 10 to the ninth per liter. Differential diagnosis, most common is gestational thrombocytopenia. The next one is 20% is hypertensive diseases. Next, it would be basically ITP, primary immune thrombocytopenia. And then you have secondary causes of immune thrombocytopenia and thrombocytopenia associated with systemic conditions, and then also genital thrombocytopenia. So going back to the gestational, it affects about 10% of all pregnancies, but it is 80% of all thrombocytopenia. Key features most commonly start in the mid second trimester or the third trimester, but it can start in the first trimester. Usually it's greater than platelets is greater than 75. Patient is asymptomatic with no history of thrombocytopenia. Return to normal after 1 to 2 months, and there's low chance of causing fetal thrombocytopenia, less than 2%. So there are 5 key features. Starts in the second and third trimester and usually over 75 patients. Number 2 is patient asymptomatic. Number 3, no history. Number 4, returns to normal after delivery. Number 5, does not cause fetal thrombocytopenia. Next, differential hypertensive diseases. This can be the first sign of preeclampsia. Primary immune thrombocytopenia. Isolated thrombocytopenia in the absence of any obvious causes. Platelet level is less than 100. It's divided by duration, if it's newly diagnosed, or if it's 2 to 12 months, it's persistent. More than 12 months is chronic. Mild ITP, usually platelet level is between 50 to 100. There is no symptoms, or there is some mild bleeding, such as cutaneous bleeding or mucosal bleeding. Severe ITP, platelet is less than 50. There's a 20% chance of postpartum hemorrhage. And the IgG antiplatelet antibody can cross the placenta and cause fetal thrombocytopenia. 10% of neonates will need to be treated, but severe hemorrhagic complications is rare, less than 1%. Then there's something called fetal neonatal alloimmune thrombocytopenia. Basically, the maternal allo it's a maternal alloimmunization to the fetal platelet, usually involving something called a human platelet antigen HPA-1A. In this situation, the mother is completely normal. It's the baby that has the problem. So 1 out of 2,000 live births, it can affect the first pregnancy. So the mother does not need to be sensitized. Normal pregnancy and delivery, or common presentation, normal pregnancy and delivery. Then the neonate develop evidence of profound thrombocytopenia within hours of birth. Usually you will see generalized petechiae or ecchymosis. There's hemorrhage into the viscera, bleeding after circumcision. There can be intracranial hemorrhage, which can occur in 50% of infants with platelets less than 50. This condition can also occur in utero in about 50% of um, fetuses with this condition. Um, so going back to other causes of maternal thrombocytopenia, so secondary immune thrombocytopenia, such as caused by APS, SLE, infections such as HIV, Hep C, CMV, H. pylori. There's also drug-induced such as heparin, antimicrobial, anticonvulsants, analgesics. Uh, Other causes can be associated with systemic conditions such as DIC, TTP, HUS, splenic sequestration, bone marrow disease, nutrition deficiency. There could be congenital thrombocytopenia. Workup, most important is a detailed history, um, trying to find out if the patient has a history or any prior deliveries affected with thrombocytopenia. We get a CBC to look at platelet count. We should always exclude other causes. If there's a sudden onset of significant thrombocytopenia, we should always exclude preeclampsia, TTP, HUS, acute fatty liver, and DIC. If it occurs in the first trimester, most likely to be ITP. If the platelet is less than 100, it's more likely to be ITP. However, if it's less than 50, it's almost certainly due to ITP, after excluding other causes, of course. Management for gestational thrombocytopenia, we check the platelets at each routine visit, and we repeat platelet count after birth, usually 3 months after birth. HELP syndrome, if there is a need for C-section and the platelet is less than 50, the recommendation is to have a platelet transfusion to bring it up to greater than 50 before the C-section. Platelets can decrease further 24 to 48 hours after birth, then rapidly recovers. ITP, Again, treatment is initiated if the patient has symptomatic bleeding, if the platelet is less than 30, or if we're trying to increase the platelet for safe procedure, which is 70 for epidural and 50 for C-section. Corticosteroids is a standard initial treatment for up to 21 days. Prednisone 20 milligrams per day initially, then adjust to maintain desired platelet count. IVIG if patient is refractory to steroids or there's significant adverse effects with steroids, or if the patient needs a rapid increase in platelet count. 1 gram per kilo, one-time dose, then repeat as needed. Peak response usually within 1 week. Versus this is like 2 to 4 weeks, I think. Splenectomy can be done in pregnancy during second trimester. Determining fetal platelet count is not recommended in ITP patients. If there is any elective procedures such as circumcision or if the neonate needs some kind of IM injection, this should be withheld until nadir of the neonatal platelets, which usually occurs within the week, 2 to 5 days. Going back to fetal neonatal autoimmune thrombocytopenia, this should be expected in unexplained fetal or neonatal thrombocytopenia, hemorrhage, or if there's an ultrasound finding consistent with intracranial bleeding. Lab diagnosis include HPA type, zygosity of both parents. We find out if the maternal antiplatelet antibody with specificity for paternal or fetal platelet. Fetal platelet count can only be attained through direct percutaneous umbilical cord blood sampling. There's a very high complication rate, which will sometimes require emergency C-section in 10% of procedures. The goal in these patients is to prevent intraventricular hemorrhage. To do that, we usually recommend early empiric initiation of IVIG with later addition of oral prednisone based on the risk of occurrence of these intracranial hemorrhages in subsequent pregnancies. I think these patients are stratified into different risks categories for subsequent fetal intracranial hemorrhages, or the severity of having these autoimmune thrombocytopenia. Chorecentesis is reserved until 32 weeks in case delivery is needed due to the complication of the procedure. If fetal platelet is less than 50, then C-section is recommended.